As the neurology topic advances, we will be dealing with most of the clinical scenarios of neurology, how to diagnose, what is the management, and other parts of neurology. Here, before everything, I would like to start with approach to neurology. So again, welcome back to Dr. Whiteboard Talks. So here we have introduction and approach to neuromedicine. So first of all, I would like to say that errors commonly result from an over reliance on the costly neuroimaging procedures and laboratory tests. When a patient is presented with a headache or fever or some other undefined fever of any cause with some neurologic manifestations, people used to start with imaging of central nervous system, mostly the brain. So when it starts with the CT brain or MRI brain, we may find or end up into some of the incidental findings that can lead or mislead us. So here I would like to say a word on this. That means errors commonly result from an over reliance on costly neuroimaging procedures and laboratory tests, which, while useful, do not substitute for any adequate history and examination. That means the most important thing, the management of neuromedicine case or approach to a neuromedicine case, is adequate history and examinations. The proper approach begins with the patient and focuses the clinical problem first in anatomic, then in pathophysiologic terms, which means we first wanted to know where the anatomic location of the lesion is, and the second thing of the approach is pathophysiologic terms. That means what is the problem going on. So here this is a small topic, that means like how to approach a patient, that's all. So only then should a specific neurologic diagnosis should be entertained. So to begin with approach, first I would like to start with define the anatomy and locating the lesion. So when and how can a lesion can be suspected, and also when to locate the lesion, or when we have to try for locating the lesion. The first priority, identify the region of the central nervous system. So region of central nervous system, can the disorder can be mapped to one specific location, or it is multifocal, or is it diffuse process. So are the symptoms restricted to the nervous system, or there is a context of systemic illness. When you work up for a case of central nervous system, you should always think in the mind that there can be a systemic illness for the lesion. So underlying lesion may be with some effect of systemic illness that should never be missed out. Now, is the problem is central nervous system or the peripheral nervous system? So the problem, whether it is found in the central nervous system or whether it is in the peripheral nervous system. So as we know, central nervous system, CNS, means that is brain plus spinal cord, as well as peripheral nervous system. What is peripheral nervous system? That means the peripheral nerves. So brain and spinal cord involves the central nervous system, and peripheral nervous system are those nerves which emerge outside the brain and spinal cord, which may include the cranial nerves as well as the peripheral nerves. So where is that affected? Cerebral cortex, basal ganglia, brainstem, cerebellum, or spinal cord. So these all are the anatomic locations where you find what is the position of the CNS that is involved, and whether it is pain sensitive. That means the meninges are involved or not. So if that is the pain sensitive meninges involved or not, that should also be localized. In the PNS, could the disorder be located in the peripheral nervous system, or if there is a motor or sensory primarily affected, or is a lesion in the neuromuscular junction or muscles? The first clues come from the history and examination. Once the history and examination gives the location where the lesion is, then we find etiology. Examples to locate the anatomic location of lesion. For an example, eccentric paresthesias and weakness. There should be a spinal cord or peripheral nerve lesion. If there is a focal back pain or a spinal cord sensory level or an incontinence, there is a spinal cord origin. If suppose there is a stocking glove pattern of sensory loss, that suggests a peripheral nerve disease. Here, the distal portion of the nerves are first affected. Irreflexia is that there is no reflex. Peripheral neuropathy can be that, or else it is a acute stage of spinal shock. Here, try to locate where the lesion is. Once the question, where is the lesion, is answered, the question, what is the lesion, is easy. Suppose a patient presents with recurrent vertigo, diplopia, and nystagmus, where there is rapid eye movements. There is a cause of brainstem or pons affected rather than to trigger it is an MS. Okay. Similarly, the combination of optic neuritis, spastic ataxic paraplegia, all these lesions, there is a chance of optic nerve and spinal cord lesions. Now I'll be discussing with functional areas of cerebral cortex. Areas of cerebral cortex can be divided into motor as well as sensory. So motor areas and sensory areas, primary cortex and premotor, as well as we have frontal and Broca's area. Whereas in the sensory we have primary somatosensory association areas, gestatory, vision, and hearing areas. So just to sum up, these were the areas of brain. Now I will be discussing a case of primary motor cortex. A fiber from the primary motor cortex is affected, and where the lesion, at what level the lesion affects, and what are the symptoms following which it happens. So if there is a lesion above, that means in the CNS, that is UMN lesion, upper motor neuron lesion, which is the effect of cerebrum as well as midbrain, medulla, and till the spinal cord. And if a lesion is below that, that is peripheral nerve, then it is LMN plus something like neuromuscular junction. If these are affected, there are other symptoms. I'm not going to the details of the symptoms because we'll be dealing with most of the symptoms later in the coming up topics. So as per the situation of the patient, we can analyze where the lesion exactly is. That is called as anatomic delocalization, or anatomic locating the anatomic lesion of the patient. Now, how to identify the pathophysiology? Here also the clues may be present in the history. Primary neuronal or gray matter disorders often present as early cognitive disturbances, movement, and other disturbances, whereas white matter disorders are usually long tract involvement. If suppose a patient has a progressive symmetric symptoms, have a metabolic or degenerative origin, then there is less likely that it should be with vitamin B12 deficiency. So to sum up, for an example, once more, like Hermite symptom. A Hermite symptom is an electric shock-like sensation evoked by neck flexion, is due to a ectopic impulse generation in the white matter pathways, as when there is a cervical spine demyelination. So if the cervical spine demyelination is there, the cord is demyelinated, it can indicate MS in a young adult, or it can be a compressive cervical spondylosis in an older patient. Sometimes the history may also suggest multiple sclerosis as well as neuromuscular transmission disorders like myasthenia gravis, and slowly advancing visual scotomas, that are visual field abnormalities or blind spot obstructing the vision with a luminous edges, called as fortification spectra, can be seen in migraine. So there is an example of here is a picture of fortification spectrum, or also called as scintillating scotoma. Scintillating scotoma or fortification spectrum can be seen as there is a scotoma surrounded by a bright illumination border. The video was about approach to neurologic case, first by locating the lesion and then by the etiology. I have made a brief idea about how to approach the case. Shall see you with the further discussions. Thank you for watching.